Thank you, Mark, and thank you, and good morning, everyone. Thanks for the invitation to speak today about this modelling study led by our team at the Burnet Institute earlier this year. So this study aimed to evaluate the impact of some of the drastic changes in the global HIV funding landscape and how those will impact low and middle income countries globally. Much of the credit of this work, of course, goes to the other people on the slide. So I wanted to start off on a positive note before we get to some of the kind of the sobering results. As a reminder, that's probably familiar to people around the remarkable progress that's been made since 2010 in reducing the global burden of HIV. So we've had a really substantial reduction in new HIV infections, more than 50% reduction in HIV-related deaths from 2010 to 2023 and continuing. And although we're not quite on target for these, on track for the 2025 and 2030 targets, the continued reduction at the year-on-year historical rates kind of makes these targets feasible by 2035. And that's despite funding for HIV not really having changed in the last 15 years. What these global trends mask, though, is that most of, or basically all of that progress has been in sub-Saharan Africa. So putting that in context, and this is courtesy of Jeff Eaton from Harvard, with UNAIDS estimates, the Asia and Pacific region has had decreases since 2010, but much of that was earlier in the period. And there's kind of a levelling off in the Asia and Pacific, while some other regions, particularly the Middle East and North Africa region, has shown increases in recent years. And so and that masks a number of kind of quite complex trends within key populations within Asia and Pacific that we'll see more of later, I'm sure. So towards the end of last year, a number of countries were already announcing significant cuts to foreign aid. And this was on top of planned reductions in PEPFAR spending. We were looking at reports from Germany, from the UK, slashing billions from aid. And these are overall international aid cuts. Of course, earlier this year, there was the sudden announcement of the stop work order for PEPFAR and the dismantling of USAID. And so we included that in this study as kind of a critical to understand what that might mean for HIV epidemic globally. So amongst international HIV funding, 5 countries are more than 90%, and the US by itself has been over 70% up until now. And so a lot of the burden of really HIV treatment globally has been taken up by the US beyond what domestic funding has been able to respond to. And so as of earlier this year in the anticipated cuts, all 5 of those top spending countries have announced kind of quite significant cuts to international aid. And if those flow through to HIV, that means there's kind of 24% overall cut in international spending, with the potential for the stop work order to impact on all of the US spending. And that remains quite uncertain, although there's kind of positive developments on that front, at least in the short term. So to understand these impacts, we use 26 existing country-validated Optima HIV models that we had done in conjunction with development partners and national teams that were based on allocative efficiency within those countries. And so we had unit costs, HIV prevention and testing spending, and how that was distributed in those countries. It covers a wide variety of countries, ranging from the largest HIV epidemic in South Africa down to one of the smallest in Bhutan. across multiple regions with quite different types of epidemic. And overall, it covers nearly half of people living with HIV in low and middle income countries and around half of international aid. And so we extrapolated these results to all low and middle income countries based on how much of the global AIDS monitoring reported spending was included in the countries that we had available to us. So to understand the impact that we needed to model, we looked at global AIDS monitoring reported spending, supplemented by some other sources when necessary. And we can see immediately that the countries in sub-Saharan Africa that we modelled over on the right are by far the most vulnerable to funding cuts, with very large proportions of international spending. Even in the country with the largest proportion of domestic spending, which is South Africa, the international spending there still represents over $400 million US per year, which is not trivial to replace quickly. So on the face of it, countries in other regions, most countries are less vulnerable to funding cuts, with that 24% of international spending representing relatively small amounts of the total budget. But that hides some of the true vulnerability, which is that prevention and testing spending is also a very small proportion of total spending, and that's where a lot of the international funds are going in most countries, particularly through the Global Fund. And it's likely that in case of budget shortfalls, quite appropriately, the HIV treatment and facility-based testing will need to be prioritised, because those are kind of urgent and life-saving interventions within national health systems, many of which have been sort of transitioned to domestic spending already, while the HIV prevention and testing spending is more likely to be funded through international sources, particularly in countries where there are maybe political sensitivities around key populations. And it's quite likely that these services may experience the majority of cuts, both through sort of lack of international funding or through the reallocation of the international funding that remains. In the modelling, we looked at this as three key scenarios. So we compared these with the status quo, where there was a fixed spending on HIV prevention and testing, and a fixed proportion of people treated based on kind of where countries are at in the care cascades now. The second scenario was to look at those anticipated cuts, where countries would have prevention and testing budgets reduced, and that may be mitigated where it's just that relative proportion, or unmitigated where basically the whole cuts that countries are experiencing come out of prevention and testing. And in this scenario, we assume that treatment would be maintained either through reallocated domestic spending as kind of a minimum priority. The third scenario was the immediate discontinuation of PEPFAR, plus those additional anticipated cuts in other countries. And this would, because of the scale of international funding in sub-Saharan Africa, this could impact quite severely on treatment and prevention of mother-to-child transmission. And that was also modelled with and without, with varying degrees of mitigation, and would represent a kind of, because of the scale of US funding, would represent nearly 80% of international spending being removed. So this is the result of that, which represents an inflection point for global HIV spending. If those most severe cuts were continued, with all US funding through PEPFAR discontinued immediately, we project that by 2030, the number of new HIV infections could kind of return to the peak of historical estimates from the early 2000s. That would mean just by 2030, up to 10.8 million additional infections and 2.9 additional HIV deaths. Mitigation could reduce that by domestic transition within some years to return treatment, but the loss to HIV prevention and testing would kind of continue increasing in the future based on our projections. With the more modest anticipated cuts where HIV treatment was not impacted, it looks on this figure to be a much more modest impact, with maybe at the low end a quite small number of additional infections and deaths if well mitigated. But the higher end of this, if we were looking at it in isolation before this year, represents what would have been a shocking 50% increase in new HIV infections over status quo. And on this line, you can also see there's a dotted line of the historical trend continued that might be possible with optimization and reallocation. So that's, remains very concerning even in the best case. There's quite a difference in these impacts. New HIV infections and deaths, of course, are not equitable. If we look across the regions and where those impacts are occurring, they're up to a 6-fold increase amongst key populations outside of sub-Saharan Africa. So within sub-Saharan Africa, a lot of HIV services are reaching all adults. So those are programs like voluntary medical male circumcision, condom distribution, and even the HIV adherence programs are reaching many more people outside of key populations. Whereas in other regions, it's mostly services for key populations that are funded at the moment for HIV prevention. And so reducing that spending means that key populations are really disproportionately affected. In the more severe PEPFAR discontinued scenario without mitigation, we see the impacts on all populations in all countries. And especially this increases the number of new HIV infections through vertical transmission to children due to reductions in spending on the prevention of mother-to-child transmission programs. And so that would mean in the order of 880,000 infections and 120,000 deaths in children in this scenario. In the Asia Pacific, we've got an asterisk there because in these 4 countries that we modelled, there was a very small number in the baseline, so it looks like it's an even higher percentage increase for those countries. For the Pacific, it's worth kind of looking at the situation in terms of international funding. So although the vast majority of international spending, when we look at dollar amounts, is occurring in sub-Saharan Africa, broken down here into the two regions of Eastern and Southern and Western Central Africa, and particularly the PEPFAR spending that's perhaps most vulnerable is in those regions. The Asia and Pacific region is also receiving a large amount of international HIV spending. And although that may be less immediately vulnerable to changes in US funding, it's still very likely that a lot of those resources may be redirected to the urgent treatment needs in sub-Saharan Africa, both in the short and longer term, as funding changes from the US. And within Asia and Pacific, there's highly concentrated HIV transmission risks, particularly amongst men who have sex with men and other gay and bisexual men. And defunding of HIV prevention services for those populations means that there's especially high risks to changes in HIV transmission. And so there's really high vulnerabilities in this region to future changes in HIV spending. Where are we now? It's very unpredictable. Some of the latest announcements are maybe more positive. The US funding is, at least in theory, continuing over the short term. Some of the latest funding proposals reported have been a 30% reduction in funding, which is worse than the anticipated cuts scenario, but not nearly as bad as immediate discontinuation. And some of the language used in these proposals is around a responsible off-ramp. So they may take the form of severe funding cuts, but with a slightly more reasonable time frame where there is some time and opportunity for adaptation, as long as that's conducted urgently. And so to summarize, there's most of our limitations and assumptions were more likely to lead to the underestimation of impact rather than overestimation under these most severe funding cuts. And this is quite similar to what although the values, particularly if we look at individual countries, vary significantly, at a global level, other modelling studies from UNAIDS and Gold's and Avenir team have reported quite similar magnitude globally. And so these abrupt or severe funding reductions for HIV, because everyone is retained on treatment for life, it's really easy for the world to lose these decades of gains that have been extremely hard fought, and particularly in sub-Saharan Africa. Other regions, including Asia and Pacific, remain highly vulnerable to reallocation of funding through HIV prevention and testing programs. And reminded globally, these cuts are likely to be inequitable. Key populations and children are likely to be disproportionately affected. So to finish as well on a slightly more positive note, in the best case, if prevention and testing services can be largely maintained, modest cuts can be absorbed without substantial increases in new HIV infections and deaths, particularly where those are applied, where countries can maintain most of those services. In many cases, there are decreasing epidemics, and it is possible to make some reductions in some places without drastic impacts. And so there's some opportunity for hope, and there may be time for countries to make these changes, but it does have to happen urgently. The changes can't happen overnight. And to promote sustainable transition and ensure progress can be continued, governments, donors, stakeholders will need to collaborate to implement feasible mitigation strategies. So thank you, and the publication is there. Happy to answer any other queries. Thanks.
Thank you, Rowan. That was really informative, and it kind of sets a scene of where we try to maintain status quo versus moving forward like we were. So I think that will be the challenge. Do we have a few minutes for questions if somebody has one?
I don't have one. I'll be the runner.
I do have a question. One of the things you're mentioning is that we're trying to maintain treatment and maintain stability. And one of the things I've seen is with the kind of imminent 6-monthly injection of PrEP as being a potential game changer, that everyone's kind of questioning now that we're trying to maintain our current state. How would this affect moving forward? Like, that's where we were on a really good trajectory, making really good impacts. And now we kind of have to pause on all that stuff to stay where we are. Is that kind of what you're hearing, seeing?
So I guess there's a hope maybe that we can continue, Jen. So on the slide with the overall impacts, we saw that the historical trend has been a year-on-year reduction, and long-acting PrEP could be a big part of continuing that without additional resources, and a big part of maybe continuing progress in countries despite funding cuts. There's also, but PrEP can't really reach people who aren't aware of the need for it. And that's the case in a lot of countries, low and middle income countries, that people are being infected and they don't, they're exposed to HIV and they don't know their risk. They don't know that they need to use PrEP. So if those basic HIV awareness and prevention programs are defunded, PrEP might not reach enough people to have the desired impact. So there's a big concern there, and that's those are decisions that are very individual country based in order to optimise the response with what funds are remaining.
Thank you, Gary McAuliffe. I'm a virologist at this hospital. So on your graph, which was fascinating, by the way, the peak deaths seem to be in that sort of 2005 to 2010, and I imagine that was predominantly sub-Saharan Africa. With the huge drop over the last 20 years, has that translated to an improvement in economic conditions in those countries, which could be translated into the domestic spending on HIV prevention and care?
Yes, so over that time, total international HIV spending has remained very constant, but the spending from domestic sources has increased, although kind of stabilising, and some of that is countries not spending money if they don't have to, and there's maybe opportunities for more absorption in some countries where economic conditions have increased more. But there's, the needs have also increased because people living with HIV continue to need treatment, even as the cost of treatment has reduced quite significantly, particularly in sub-Saharan Africa. But yeah, there's a ongoing need in countries.
Oh yeah, hi, Nigel Raymond. I'm an ID physician. So ASHM's an Australasian society. So what implications do you think that might have for Australia and New Zealand in supporting the Pacific region?
Yeah, I think any reallocation of resources from other global sources means that for Australia and New Zealand and other sort of high-income countries in the region end up with more responsibility for this region to maintain services, or I guess at least to provide technical support to countries where they may be able to fund but lacking some of that capacity.
Kia ora. I just had a question about the guideline. This is not to do with funding, but I've heard that due to the Trump funding cutting services, there could be an impact on the access to the DHHS guidelines, and I was wondering if you knew what might happen in that space.
I don't know what would happen in that space. There's certainly the guidelines certainly, I guess, exacerbate some of the things that we did model in terms of the guidelines for US funding now are probably leaning towards being strictly for treatment and some of the more urgent programs, which, we would agree the priority for treatment to maintain life-saving treatment. But that does mean that a lot of these other services and guidelines, and we've seen really severe impacts in many countries. Like I know in Mozambique, a lot of the electronic systems were kind of offline and difficult to access. And there have been many impacts over this year, even if funding is in theory continuing.
And we just have one more question.
I'm Clara Dawkins, coming from the Drugs and Alcohol Services in Auckland. I wonder, just been to the Drug Harm Minimization Conference in Bogota, where we spent 4 hours discussing the impacts of the fundings and the war. Is there any registry around from different countries that they can have an awareness or some visibility of the changes of the people who are being affected? How many people are stopping treatment? Or is there anything that we can do to raise that visibility? This American Lab did a podcast with people in Africa and show kind of the reality on the ground of what happens when the funding is cut. Is there anything that we can do? Because these progressions, yes, is very sad and difficult, but how can we raise that we can increase funding? Do you see what I mean? Sorry, I don't know.
It's a complex question. One of the big challenges with the funding cuts is the extent to which one of the first things that maybe goes for countries is the reporting systems as not being urgent life-saving care, and that will make it, and monitoring systems, which may make it difficult to kind of improve responses in the future, to optimise the response. And while that maybe doesn't directly answer your question, it does. I guess I'd just agree that that is a challenge going forward, and that's where UNAIDS and WHO and other organisations can kind of be better placed to think about that level of reporting. But they're also experiencing funding cuts, and it makes it more challenging in the future. So I'm sure they welcome any support. Thanks.
That was great. Thank you, Ron. That was a really good update. Thanks.